All right, friends, let us continue with the video discussion. Now, coming back to question number 10. Now, question number 10 is dealing with labor, right? So let us see what question number 10 says. Question number 10 says that in a vertex presentation, the diameter of engagement is, the answer is A. It is suboccipito-bregmatic, all right? So these, knowing the diameters of the skull and knowing the dimensions of the pelvis are very, very important, all right? Why is it important? Because simple one-liners are often asked from these topics, all right? So what we are going to discuss now is question number 10, question number 77, question number 83, question number 124. All right. Now all these questions, they deal with the pelvis and labor. All right. So pelvis and labor, these are the questions that deal with that. In question number 23 and question number 63, we are going to deal with partogram. All right. So we are going to talk about partogram in this question, and your question number 20 and question number 106 is another question that we will deal with, and your question number 20 and question number 106, they deal with active phase and partogram and all those things. We will deal with that. So these are the questions that these are the next questions that I am focusing on discussing, and to be able to answer these questions, I want to discuss with you in detail a little bit maternal pelvis, the skull, and we'll talk about the labor, and after that we'll talk about the partogram. Right? So this is what we are going to talk about. All right, so let us proceed with our discussion first, and then we can come back and do these individual questions one by one. All right. So now talking about the fetal skull. Okay, talking about the fetal skull. Okay, what you have to remember? You have to remember that what are the transverse diameters and what are the AP diameters, right? So let's talk about the transverse diameter first. You remember that the transverse diameters, they are always smaller than the AP diameters, okay? Because sometimes in NEET PG what they ask this, that which of these among the four, they will give you options. 4 options, you'll have to answer which is the longest, which is the smallest, this phase, all right? So if they are all the diameters of the fetal skull, remember that the transverse diameters, they're always smaller than the AP diameters. You will have to remember which diameters are 9.5 centimeters. So that you will remember at least 3 diameters which are 9.5 centimeters, so we will rule them out. Then you'll have to remember that the AP diameters are always bigger than the transverse diameters, or transverse diameters are smaller. So in the transverse diameters, let us go one by one. We have the biparietal diameter, which is 9.5 centimeters. Right, and the significance of this biparietal diameter is that once the BPD crosses the pelvic brim, the significance of this biparietal diameter is that once the BPD crosses the pelvic brim or the inlet, that means the head has become engaged. Okay, this is what biparietal diameter represents. Then we have the subparietal diameter. Subparietal diameter is 8.5 centimeters, and it is the diameter in the asynclitic head. Okay, it is the diameter in the asynclitic head. Then we have the bitemporal diameter. This bitemporal diameter is 8 centimeters. And the fourth diameter is the bimastoid diameter, and this bimastoid diameter is 7.5 centimeters. So in fact, the bimastoid diameter is the smallest of all AP and posterior included. Alright, so this is the smallest. It is the non-compressible diameter. Right, it is the non-compressible diameter, which is the bimastoid diameter. Alright, so these are the 4 diameters which we have to remember in the fetal skull. These are the transverse diameters. Coming to the anteroposterior diameters of fetal skull. In the anteroposterior diameters of the fetal skull, if we go sequence wise, then the longest is the mentovertical, which is 14 centimeters, and this is in brow presentation. Then we have the occipitomental, which is 12.5 centimeters, and this is the diameter in which forceps are applied. Forceps are applied in this diameter. This is another point that you have to remember. So, mentovertical, occipitomental. Then we have the submentovertical and the occipitofrontal. Both are 11.5 centimeters. Occipitofrontal is the diameter in ROP position. Okay. Then suboccipitofrontal. This is around 10 centimeters, and the aftercoming head of breech engages by the suboccipitofrontal, right? Both these diameters, the occipitofrontal and the suboccipitofrontal, they are diameters of deflexed head. Both of these are diameters of the deflexed head. And then we have the submentobregmatic, which is seen in face presentation, and we have the suboccipitobregmatic, which is seen in the vertex presentation. Both of these diameters are 9.5 centimeters. Alright, so this is how you will remember all these diameters. Alright, these are the AP diameters of fetal skull. Alright, so we have the mentovertical, which is then in the brow presentation, occipitomental, the forceps are applied in this diameter, submentovertical, occipitofrontal, this is the diameter in ROP position. Another important point about occipitofrontal diameter is, another important point about occipitofrontal diameter, this occipitofrontal diameter another important point about this diameter is that it is seen to distend the vulval outlet in phase to pubis delivery, right? And this phase to pubis delivery happens in the direct occipito-posterior position. And this direct occipito-posterior position is seen in an anthropoid pelvis. Alright, and this diameter is 11.5 centimeters. So when this happens, when the phase to pubis delivery happens, what happens is that there are more chances of perineal injury. Okay, when this bigger diameter is distending the vulval outlet, then these are the problems that can happen with the phase to pubis delivery. Alright, so these are the important points about the fetal skull. Alright, coming on to the maternal pelvis. Okay, what are the important points that you should remember about maternal pelvis? When we are talking about the maternal pelvis, we are going to talk about the important points that you should remember in the inlet, right? We're going to talk about the mid pelvis, and we're going to talk about the important points of the outlet, and we're going to talk about the types of pelvis. Alright, so these are the important bits that we have to remember. Now what are the important points about the inlet? Now the inlet is all bony. First of all, we remember that. Alright, now inlet, if we see, this is the maternal inlet I am talking about. Okay, so this is the inlet we are talking about, and if I show you in this diagram, we will see that this diameter, these are the anteroposterior diameters of the inlet. Okay, so let me talk about the pelvic inlet. We're talking about the AP diameters of the pelvic inlet. Okay, and when we're talking about the AP diameters, this is what I want you to see, that this diameter, which is extending from the tip of the symphysis pubis to the sacral promontory, this here is the sacral promontory, right? This here is the sacral promontory. This, from the tip of the symphysis pubis to the sacral promontory, is the true conjugate. This, on the other hand, from the back point of the symphysis pubis to the tip of the sacral promontory, is the obstetric conjugate. And this, from the lower point of the symphysis pubis, lower border of symphysis pubis to the sacral promontory, this is the diagonal conjugate. Okay, so we see we have three main anteroposterior diameters: the true conjugate, the obstetric conjugate, and the diagonal conjugate. Right? The important point to remember is that it is the obstetrical conjugate which is the smallest, and it is the diagonal conjugate which can be the measured clinically. Okay, so there are certain important one-liner questions that are asked in these questions. Is that the shortest AP diameter of the inlet, the shortest AP diameter of the inlet, if they ask you this question, the shortest AP diameter of the inlet, that is the obstetric conjugate. Okay, in fact this obstetric conjugate is so important. All right, this obstetric conjugate is very important. All right, now another important point, if you can see here, is that only the diagonal conjugate can be measured clinically. What is happening in this figure here? In this figure here, if this figure is given to you to identify, you can identify this is what is being measured. Measured here in this figure is the diagonal conjugate. So it is only the diagonal conjugate which can be clinically measured, which is the diagonal conjugate, and this diagonal conjugate is around 12 centimeters. And the obstetric conjugate is calculated as diagonal conjugate minus 1 8.5, so the obstetric conjugate is about 10.5 centimeters, right? And what is the transverse conjugate? True conjugate is about 11 centimeters. So these are the three important anteroposterior diameters: diagonal conjugate, obstetric conjugate, and the true conjugate. All right. In fact, it is said that if the obstetric conjugate is less than 10 centimeters or diagonal conjugate is less than 11.5 centimeters, it means that it is a contracted inlet. Another important point is this angle of inclination. Angle of inclination is the angle that is made by the pelvic inlet to the horizontal. This angle made by the pelvic inlet, all right, by the plane of the pelvic inlet to the horizontal, this angle is the angle of inclination. This angle is the angle of inclination, and this in a normal standing upright woman is around 55 degrees. All right. Sometimes this angle of inclination can be high. High means more. Okay. So sometimes this question has been asked that what is high inclination? High inclination means that the angle is increased. High inclination is seen with sacralization of lumbar vertebra. Sacralization of lumbar vertebra, and this high inclination is associated with right occipito-posterior position. Okay, this is associated with the right occipito-posterior positions. So these are the important points you have to remember about the inlet. All right. Now talking about the mid pelvis. Okay, now talking about the mid pelvis. When we talk about the mid pelvis, in the mid pelvis we have the one diameter that you have to remember. Mid pelvis is also called as the plane of least pelvic dimensions. We remember this much, that it is also called as the plane of least pelvic dimensions, and in this lies the interischial spine diameter. Interischial spine diameter, which is the IID, and this is 10.5 centimeters. Now if they ask you a blanket question that which is the shortest diameter of true pelvis, right, or if they ask which is the most important diameter of true pelvis, then the answer to that question is the interischial spine diameter. However, your both obstetric conjugate and interischial diameter is 10.5 centimeters, but when answering the shortest diameter of true pelvis or the most important diameter of true pelvis, it is the IID because it is in the mid pelvis. Another important question, whenever the IID is less than 8 centimeters, it means that there is contracted cavity. Okay. Next important point you have to remember is about the outlet. Now what you have to remember about the outlet we have two outlets. We have the anatomical outlet and we have the obstetric outlet. Now anatomical outlet, it is all bony, and the obstetrical outlet is nothing but a space. The anatomical outlet is nothing but the space, and this the obstetric outlet is nothing but a space, and for the obstetric outlet, the roof of this obstetric outlet is formed by the plane of least pelvic dimensions. The important point to remember is that the plane of the outlet, right, the plane of the anatomical outlet passes lateral to the ischial tuberosity, and the plane of the obstetrical outlet that passes lateral to the ischial spine. Okay, these are the two important things to remember, that the plane of the anatomical outlet passes lateral to ischial tuberosity and that of the obstetric outlet passes lateral to the ischial spine. Another important point to remember in the outlet, what are the other important features of the outlet? For the outlet, you have to remember that we are measuring the subpubic angle, right? The subpubic angle normally is about 85 degrees. Then we are measuring the transverse diameter of outlet, which is the TDO, which is around 11 centimeters, or clinically 4 knuckles tight. And if the transverse diameter of outlet is less than 8 centimeters, it means that there is contracted outlet. Okay, so these are the important points to remember there. Now, important question that they ask is that when is pelvic assessment done? Okay, when is pelvic assessment done? These are all the features that we see during pelvic assessment. Okay, pelvic assessment, when is it done? Now, pelvic assessment is done in a primigravida. Pelvic assessment is done at 37 weeks, and in a multigravida, pelvic assessment is done at the onset of labor. Okay, at the onset of labor. Similarly, what is the best method for pelvic assessment? The best for pelvic assessment is actually trial of labor, then followed by clinical assessment. Alright, so similarly this question can be asked in another language, in another form, like what is best for CPD prediction, cephalopelvic disproportion prediction, what is best for CPD prediction? Then the answer to that question is trial of labor and then clinical assessment. Alright, very important point is that if there is CPD at cavity or outlet, then there is no trial of labor, then the management is cesarean section. But if there is mild CPD at the level of inlet, right, then in those cases trial of labor can be given. Alright, these are the two important points to remember about pelvic assessment. First, that for CPD prediction the best is trial of labor. If there is CPD at the cavity or outlet, then the management is cesarean section. If there is mild CPD at the level of inlet, then trial of labor can be given. Alright, now we come to the various types of pelvis. Alright, we come to the various types of pelvis. Coming to the various types of pelvis. Okay, what are the important you have to remember? The normal or the most common type is the gynecoid pelvis. Okay. Then there are four parent clinical types. Alright, 4 parent clinical types, and after that there are always combinations. Okay, there can be a lot of combinations between the anterior and posterior segment, and the combinations, usually combinations, but the most common type is the normal gynecoid pelvis. And then you have the male type, which is the android pelvis. Now, what are the important points to remember about the android pelvis? Android pelvis is the male type. The inlet is triangular. The side walls are going to be, it is going to be triangular. The inlet is going to be triangular, right? This will be the posterior segment, this will be the anterior segment. Similarly, it is going to be triangular like this. So the ischial spine, the interischial diameter is going to be less, the subpubic angle is going to be narrow. So these are the important findings that you can write down, that the interischial diameter is going to be less, there is going to be the subpubic angle is going to be acute, it is going to be less than 85 degrees. But the most important point about android pelvis is that this pelvis is the most common cause of right occipito-anterior position. Alright, the most common cause of right occipito-posterior position, is your android pelvis. Alright, so this is important point that you have to remember, as the most common cause of right occipito-posterior position is the android pelvis. Another thing is that this pelvis is associated with deep transverse arrest. That is seen with this pelvis. Another important point about this pelvis is that dystocia dystrophica syndrome is seen with this pelvis. Another important point is that there are greater chances of cesarean section, with this particular pelvis. Alright, so these are the important points about the android pelvis. Alright, next important pelvis is the anthropoid pelvis. Okay, the next important pelvis is the anthropoid pelvis. Now this anthropoid pelvis is the only pelvis, it is the only pelvis in which the AP diameter is more than the transverse diameter. That means that it is anteroposteriorly oval. Okay, the AP diameter, this AP diameter is more than the transverse diameter. This is the only pelvis in which such a situation exists. Okay, very, very important point, anthropoid pelvis. And what are the important points about this anthropoid pelvis? I told you it is associated with direct occipito-posterior position. It is face to pubis delivery will happen in this kind of a pelvis. And another important point, that there will be more perineal injury, chances of more perineal injury chances in this kind of pelvis. Another important pelvis is now the platyploid pelvis. This platyploid pelvis is also called as the flat pelvis, right? And this flat pelvis is basically the pelvis which is associated with your transverse lie, which is associated with your brow and face presentations, right? These abnormal presentations are happening with platyploid pelvis. Another important point, that the head in a platyploid pelvis, the head engages by exaggerated posterior parietal asynclitism. So this is all P. Okay, so remember platyploid, remember posterior parietal asynclitism, and this is mainly seen in primi-gravidas, right? So this we can remember, this is the posterior parietal asynclitism which is seen in platyploid pelvis, seen most commonly in the primies. And then you have the certain special types of pelvises, like you have the triradiate pelvis, which is seen in severe rickets, and osteomalacia. Then we have the Roberts pelvis, and we have the Naegeli's pelvis. All right, so in Roberts pelvis there's B, so both ala of sacrum. Okay, B for Roberts in B, and both ala of sacrum, they are absent in Roberts pelvis. In Naegeli's pelvis, one ala absent of sacrum absent. So they are grossly deformed pelvises. These three types are grossly deformed pelvises that are there. All right, so this is what you have to remember about the maternal and maternal pelvis and the fetal skull. This is the basic bare minimum that you have to remember. All right. Coming back to this figure here, I wanted to show this to you. Sometimes that they have asked figure based questions also on this. Like this is the vertex pose. The first diagram here shows, first figure A shows here the vertex. This shows here the deflexed head. All right, deflexed head. This here is sometimes asked, this is called as the military position. This is called as the military position. Sometimes the brow presentation is also called as the military position. Okay. So this is the brow and this is the face. There is extreme extension. There is extension of the head, and this is the face presentation. So these are the important points that you should remember. What is important to remember? Question has been asked about this military position, which is for the brow presentation. This question was asked in recent exams. Now, talking about the cardinal steps of labor, I want to talk about the cardinal steps of labor. So importantly, I want to give you what are the cardinal steps of labor. The cardinal steps of labor are basically your engagement, right, descent and flexion, your internal rotation, extension, which leads to the delivery of head is by extension. Then we have the restitution, sorry, not restitution, we have the external rotation and the expulsion. All right, so these engagement, descent, flexion, internal rotation, extension and external rotation and expulsion, these 7 steps are the cardinal steps of labor. Remember that restitution is not a cardinal step of labor. So engagement, descent, flexion, internal rotation, extension. All right. Now another important point about this I want to tell you is, let's talk about each of these and remember the important points in each of these. All right. So talking about engagement. All right. So when do we say that engagement has taken place? This is very important. Talking about engagement, we say that engagement has taken place when the biparietal diameter had crossed the pelvic brim. So once the biparietal diameter engagement, important points to remember about engagement is that the biparietal diameter has crossed the pelvic brim, right, and the vertex, the leading point of the vertex is at 0 station. All right, and this will happen when on per abdomen examination the head is 1/5 or 0/5 palpable. Okay, so this is what is the definition of engagement. These are the 3 important points about definition of engagement. All right, important point again to remember is that in primigravidas engagement happens earlier. All right, important point to remember is that in primigravidas engagement happens earlier, and in multigravidas engagement does not happen maybe even till the onset of labor. All right. Another important point about this here is that the most common position, if they ask you what is the most common position, like shown in the diagram here, in which the fetus enters the pelvis. All right, that means in the beginning of labor is left occipitotransverse. All right, so the most common position in which the fetus enters the pelvis is left occipitotransverse. Because it is in left occipitotransverse, we realize that the internal rotation, during the internal rotation, important points to remember is that the head rotates 2/8 of a circle and the shoulder rotates 1/8 of a circle in the same direction as the head. Now another important point to remember from this about the internal rotation and flexion and descent is that the most important factor which favors descent and flexion, all right, the most important factor which favors descent and flexion is basically uterine contractions. So if there are good uterine contractions, flexion is going to be maintained. If there is flexion, descent is going to happen. All of this happens together. Good uterine contractions means flexion maintained, means descent happening. All right, so that is why the most important factor which favors descent and flexion together is the uterine contraction. Secondly, important points about internal rotation. All right, second point, most important point about internal rotation. What is it about internal rotation that I want you to tell you? internal rotation. Now internal rotation, what happens during internal rotation? Internal rotation, the occiput comes to lie behind the symphysis pubis, right? The occiput will come to lie behind the symphysis pubis. That is what is happening, right? And internal rotation happens at the level of pelvic floor, at the level of ischial spines. Ischial spines are the level. At this level, what is happening? The levator ani are inserting at this level, right? And the fibers are anteriorly inclined, anteriorly and medially. That is why internal rotation of occiput happens to the internal rotation happens. That is why, because of the fibers of levator ani which are inserted or which are traversing this pelvic floor medially and anteriorly. That is why internal rotation happens. And another important field, the favors which are question is asked on this, that what favors internal rotation? What favors internal rotation? So internal rotation is favored by favorable pelvis. Alright, if favorable pelvis, there is going to be internal rotation. So favorable pelvis like gynecoid pelvis. In an android pelvis, like I discussed earlier, there will be incomplete rotation and there will be transverse arrest. Okay, deep transverse arrest. Similarly, in anthropoid pelvis, it goes posteriorly. The occiput goes posteriorly, giving the direct occipito-posterior position. So favorable pelvis, good contractions, well flexed head, these are the things which are going to favor internal rotation. Alright, so these are the important points that you should remember about the labor. These are the important points that one should remember about labor. Now we will come to discussion of the partogram. Alright, now we will come to discussion of the partogram. Let us discuss partogram in brief here. Talking about the partogram. Alright, now what I want you to remember about the partogram is, first of all, important point is that is given by WHO, which is the modified WHO partogram. Okay. And in this modified WHO partogram, we can measure the fetal heart rate, the patient characteristics. They are also mentioned here in the gravida para. The Liker is also mentioned. We trace the dilatation, we trace the descent, right? We trace the contractions. We are tracing the oxytocin, whatever we are giving, and the IV fluids, whatever we are giving, right? Pulse rate, BP, temperature, all these are charted. Urine, protein, ketones, and albumin. This is also charted. So these are the basic things that are charted in this partogram, right? Another important point you have to remember at this big box and these small boxes, right? Now there are these small boxes and the big boxes. The small boxes, they represent 30 minutes and the big boxes here represent 1 hour. Okay, another important point, the contractions are plotted here. So when the contractions are plotted here, you have to remember that the contractions are plotted, the number of squares, contractions are plotted every half hourly, as you can see here. So the number of boxes that are covered show that the number of boxes that are that are covered will show how many contractions are there. For example, if there are 3 contractions, 3 boxes will be shaded. If there are 4 contractions, 4 boxes will be shaded. So it is something like this: 1, 2 contractions, or maybe 3 contractions and then 3 contractions, like this. If The if these are dotted boxes, that means these are mild contractions. If these are dotted boxes, it means mild contraction. So 3 mild contractions, okay. If they are lined boxes, it means that these are moderate contractions. And if these are completely shaded like this, blackened boxes, then it means that these are good contractions, okay. So this is how we will see the partogram. And this is important to know, that what are these contractions look like. Question about the contractions has been asked from you in this test series also. So this much at least bit you should remember about the partogram, that what are the characteristics that are plotted in the partogram, how are the contractions plotted in the partogram. The number of contractions is represented by the number of boxes painted, like these are 2 mild contractions, these are 3 moderate contractions, 3 boxes, so 3 moderate contractions, all right. And then very important, coming back to what about the alert line, action line, and what is all this here. How is this plotted? Very important. Let us see next, how is this plotted. Let me show you here. Look at this. Now in this figure here, how is it being plotted? As you can see that here the contractions are being plotted, they are lined, so that means these are 3 moderate contractions. Here these are all blackened, so initially there are 3 moderate, then there are 4 good contractions, right. Then for the most of the part there are 4 good contractions in each half hour. These small boxes is each half hour, the big boxes is 1 hour, so time here is plotted. So let us say whatever the first plot of dilatation always happens to be left of alert line, okay. It always happens to be on the left of alert line. So let's say example, I examined the woman at 10 p.m. Now this figure diagram shows 10 p.m. So let's say 10 p.m. that I examined the woman and she was 4 centimeter dilated. I will plot it here. If she was 6 centimeter dilated, I would have plotted it here. If she was 7 at that point, I would have plotted it here. 5, I would have plotted it here. So the first plot of dilatation will always be to the left of the alert line, right. So this is what the first plot is made, and this is 3 here shows the -3 station, all right. So this is the 4 centimeter here, it begins from 0. You have to plot the descent, if it is -3, it will be plotted here. If it would have been anything else, -2, -1, it would have been plotted accordingly, all right. So the first plot of dilatation is always to the left of alert line, according to our WHO partograph, which most of us are following in our labor rooms in our country. The active phase according to this WHO partogram begins at 4 centimeter dilatation, all right. Now with the latest Williams and with the latest American guidelines, they are saying that it should be 6 centimeters and not 4 centimeters. Why they have come up with this is that they are just saying that any cesarean for arrest of dilatation or arrest of descent should be taken once it is more than 6 centimeter dilated. But for us, we will still say that WHO partogram, that is the one the majority of the people in our country are currently following. The active phase according to that is 4 centimeters, and our partograms are also developed according to that, right. Now during this active phase, this is according to the WHO partogram, this is plotted, this alert line is plotted so that it is 1 centimeter per hour. 1 centimeter per hour at least is the dilatation, right. But if they ask you what is the rate of dilatation, sometimes they've asked this question, what is the rate of dilatation in active phase, okay. What is the rate of dilatation in active phase? So in primigravidas, it is around 1.2 centimeters per hour, and in multigravidas, this rate of dilatation is about 1.5 centimeters per hour, right. Now if these rates of dilatation are to be maintained, we will simply establish that the graph should always be to the left of the alert line, or at least following the alert line, right. The slope of the graph should at least be that. Now in this patient, in this woman, what has happened happened that 4 hours later, 11, 12, 1, 2 p.m. At 2 p.m. when she was reassessed, she was only from 3, she had moved on to only 6 centimeter. So the alert line had been crossed. The alert line had been crossed, and in the meanwhile, what had happened to the contraction? The contractions were still moderate, right? So what was done? Contractions probably have become good in the later part of the cycle, probably by giving oxytocin or whatever. And then what has happened is that with four good contractions for the remaining 4 hours. Again, she is assessed after 3 more hours, right? 3, 4, 5 p.m. When she is reassessed at 5 p.m., she is 10 here, and then at 2 p.m. she is assessed here. Then at 5 p.m. when she is assessed, what has happened? She is still from 5 to 5 centimeters only, from 6 centimeters to 6 centimeters only, isn't it? So what has happened in this partogram? This is called as arrest of dilatation, all right. So we can appreciate that in the first part of the partogram, in the first 4 hours, what happened was that there were moderate contractions. Now what are we interpreting from this partogram? We are interpreting that in the first 4 hours, what happened was there were moderate contractions. She was admitted at 4 centimeters, but even after moderate contraction, she failed to dilate at the expected rate, which is 1.2 centimeter per hour in primi and 1.5 centimeter per hour in multi. She failed to progress like that, and so the alert line was crossed. Once the alert line was crossed, what happened is that let's say we started oxytocin to increase the contractions, and we were able to achieve 4 good contractions. Now for the next of the 4 hours, she is getting good contractions, right? As we can see, between 2 p.m. and 5 p.m. she is getting good contractions, but despite 4 hours of good contractions, what has happened? She has failed to dilate from even a centimeter beyond 6 centimeters. So this is called as arrest of dilatation, which has happened here in this, and ultimately this woman had to undergo a cesarean section. All right, so this partogram here is showing arrest of dilatation, right? All right, so this is what is about the active arrest of dilatation, and this is about this part of the partogram. If you look at the next partogram here, I will like to show you here that if you can appreciate in this partogram, what is happening is that at 5 a.m. let's say she was, disregard this latent phase, okay, disregard this latent phase, because now there is no longer any latent phase. Let us say that we began plotting her dilatation at 3 centimeters, and at 4 hours later she was 6 centimeters, and then this was also slow. The alert line had been crossed, but let's say at 5 p.m. she has managed to somehow, reach your full dilatation. Full dilatation is 10 centimeters. Another important point, full dilatation is 10 centimeters. So she has managed to reach, albeit a bit slower, she has managed to reach full dilatation, but what has happened in the meanwhile is that the descent has got stuck. There is no descent, right? So this is called as arrest. So there is no descent. This is called as arrest of descent. Okay, in this there has been absolutely no descent. This is called as arrest of descent. All right. So now coming back to an abnormal partogram. Okay, now this is what is an abnormal partogram. So these were the partograms which were there earlier when a latent phase was included in the partogram, right? So these are certain old questions where the latent phase was still included in the partogram, but still I would like to for you people to know that latent phase is no longer included in the WHO partogram. Latent phase is no longer there in WHO partogram. Okay, the modified form does not have a latent phase. However, we say that the latent phase is prolonged when in primigravidas, if it is more than 20 hours in primigravidas, and in multigravidas if it is more than 14 hours, it means the latent phase has prolonged, right? Similarly, we have the protracted active phase. Protracted active phase means that the active phase is slower than normal, right? That means the rate of dilatation is less than 1.2 centimeters per hour in primigravida and less than 1.5 centimeters per hour in multigravida, right? So this, like figure B here, B would show that the slope of dilatation, the slope of the cervical dilatation has become less. So figure number B is showing what is called as protracted active phase. Figure number A here is showing the prolonged latent phase. And figure number C here, what is C here showing? C here is showing secondary arrest of dilatation. Secondary arrest of dilatation means that the dilatation initially proceeded normally, but then there was arrest of dilatation, it got stuck. Okay, so what is the diagnosis of arrest? For arrest of dilatation, the diagnosis is made after 4 hours of adequate contractions, okay? After 4 hours of adequate contractions, or after 6 hours of oxytocin, right? There is no change in cervical dilatation. Then there is arrest of dilatation, and she should be at least 6 centimeter dilated minimum to make the diagnosis, before making the diagnosis of arrest of dilatation. So this is what is important in the arrest of dilatation part, and this is what the change in the latest edition of Williams has been, and the latest ACOG guidelines say that before taking cesarean section for arrest of dilatation, she should be at least 6 centimeter dilated. That is what is said, right? So now I will give you a flow chart which will help you answer the questions, the clinical questions based on the labor management, and that will help you answer those questions and will help us understand what we have so far sought in the partogram. All right, so let us say that there is a patient with uterine contractions, the patient with uterine contractions in labor. All right, this is how a question will be framed to you. A multigravida or a primigravida is in the labor room getting mild contractions or good contractions or moderate contractions, right? Right, so patient with uterine contractions and in labor. All right, now what is important for you to understand first is that what is true labor and what is false labor, right? So she could be in false labor. False labor would be there will be no change in dilatation, right? No change in dilatation or effacement. So progressive dilatation and effacement is the best sign of true labor. In other words, if they ask you what is the best sign of true labor, what is the best sign of true labor, the answer is progressive, not static, progressive dilatation and effacement. Progressive dilatation and effacement of cervix, that is the best sign of true labor. So this will be the first answer. If this is not in the options, then progressive dilatation and effacement ultimately will lead to bag of membranes. So this will be your second choice, okay? So progressive dilatation effacement ultimately leads to bag of membranes. So the first choice would be progressive dilatation and effacement of cervix, that will be this thing. So if she is in false labor, she does not need to do anything. She just needs rest, right? Rest and sedation. She just needs rest and sedation and pain relief. Pain relief in the form of antispasmodics will be able to relieve this false labor pain of hers, right? But if she is in true labor, right? If she is in true labor, if she is 0 to 4 centimeters, right? Or let's say somehow the New Williams says that up to 6 centimeters, okay. So that way she would be latent phase, right. Then in that case the management is sedation and rest, okay. Sedation and rest, this is the management, sedation and rest. So if the woman say, if the question is asked, a woman comes, a question is asked, let's say a woman has come in labor with mild contractions and she is 2 centimeter dilated, after 10 hours she is still the same, then what is the management? The management is again management and rest, sedation and rest. Why? Because the definition of prolonged latent phase is made after 20 hours in primary and 14 hours in multi. So we do not make the diagnosis of prolonged latent phase here. Now what are the causes of prolonged latent phase? The causes of prolonged latent phase could be, the process of prolonged latent phase could be excessive sedation, epidural, or poor cervical condition, okay. These could be the causes. Now next important point is very important, this here. What do we do when she is in the active phase? Okay, so let me give you a flow chart here. Whenever she is in the active phase, she is more than or equal to 4 centimeters or 6 centimeters according to the new WHO guidelines, we will see what the contractions are like. In the question, see what are the contractions like, okay. So if the contractions are slow, if there are slow contractions, then you'll have to see that if the bag of membranes is present, we will do artificial rupture of membranes followed by plus minus oxytocin if required. And if the bag of membranes has already ruptured, it is absent, then we have to give oxytocin to increase the contractions. If the contractions are already adequate, adequate contraction means, what does adequate contractions means? Adequate contraction means around 220 Montevideo units, okay. Montevideo units is the units in which contractions are measured, okay. So if the contractions are adequate, then we have to assess for presence of CPD or deflexed head, right, or occipito-posterior position. We have to see the pelvis whether it is adequate or no. And if in the question, if the question says a woman is 6 centimeter dilated with 4 hours of contractions, good contractions, yet no change in the findings, and there is caput formation or molding formation in the PV examination, right, molding especially grade 3 or grade 3, these will go in favor of these findings, caput, grade 3 molding in the PV in the setting of arrest of dilatation, adequate contractions for 4 or more hours, right. This kind of a clinical picture if given to you, okay. A woman who had 6 centimeter dilatation, who for 4 or more hours of good contractions is still 6 centimeter dilated, she has not progressed, and on PV examination if there is caput molding or grade 3, then this will go in favor of CPD, and arrest of dilatation, this will go in favor of CPD. These findings will go in favor of cephalopelvic disproportion, and then in that case the answer would be cesarean section. Okay, so this is heading towards arrest. The cause of arrest in this situation would be CPD, and then the management would be cesarean section. So this is how such questions are going to be attempted about labor. All right, so now let us see the questions that we wanted to discuss in the beginning. Let us see the questions that we wanted to discuss in the beginning. All right. All right. Now let us see question number Let us see question number 10. Question number 10 we have answered already. It is suboccipitobrachmatic diameter. Coming on to question number 77 now. Before that, let us see question number 23. Question number 20 and question number 23 are also there. Question number 20. See, what is the rate of cervical dilatation in first stage of labor in multigravida? So, in first stage of labor in multigravida, we are specially talking about obviously we are talking about the active phase here, and it is 1.5 centimeters per hour in multigravida. In primigravida, it is in primigravidas, I told you it was 1.2 centimeters per hour, and this is in the active phase. Alright, this is in the active phase. Moving on to the next question, question number 23, I wanted to talk to you about, like this here in this question when we talked about this, yes, here. Question number 23, what does B here show? No, what is being asked? Let me just check. What does B indicate in the following partogram? So, in the following partogram, A represents mild contractions, okay, B represents moderate contractions, and C represents good contractions. In fact, talking about uterine contractions, I want to tell you some important bits about uterine contractions, that when we say moderate contractions, okay, these moderate contractions, when we say moderate contractions, we mean that these contractions have at least an intensity of 40 mmHg. Okay, at least they have an intensity of 40 mmHg. Those are moderate contractions. Then we have those Braxton Hicks contractions, which are, Braxton Hicks, these are painless uterine contractions which happens throughout pregnancy, and their pressure is somewhere around 8 mmHg. Average around 8 mmHg, but around 8 to 10, all right. So the contractions, the uterine contractions, they become palpable. They become palpable at an intensity of 10 mmHg. The contractions, they become painful, or let's say they become capable of producing cervical dilatation when they are at an intensity of 15 mmHg, right. In the first stage of labor, the contractions are somewhere between 25 to 50 mmHg. The intensity is around 25 to 50, 25 in the early first stage and 50 in the late part of this thing. In the second stage of labor and in the third stage of labor, the contractions intensity is same at around 100 to 120 mmHg. So this is important bit you have to remember about the uterine contractions. Another important point about uterine contractions is that there is fundal predominance. Fundal predominance. They are the pacemaker of these uterine contractions is the cornu, the right more than the left, and there is a wave of depolarization of uterine contractions. It travels at the rate of 2 centimeters per second, and it depolarizes the whole uterus in about 15 seconds, okay. So these are the important bits that you have to remember about the types of uterine contractions that there are and the intensity of uterine contractions that is there, right. Now I told you that the intensity of uterine contractions, the strength of uterine contractions is measured in a unit which is called as the Montevideo units, right. And in this Montevideo units, MV units, how is it given? It is given by this formula, that is number of contractions, all right, in 10 minutes multiplied by the intensity, average intensity of each contraction. For example, if there are 4 contractions in 10 minutes and with each, the average intensity of each contraction is about 40 mmHg, then the Montevideo units would be 160 Montevideo units. This would be the strength of the uterine contractions. Okay, so this is another important bit that I needed to tell you about the Montevideo units. Okay, now coming back to the next question, which is the next question that we have to see. Let us see the next question, question number 23. After that, let us see question number 63. Okay, look at this here, question number 63 about labor again. Let us see this question. True about partograph is all except, right? So each small square, so partograph, each small square represents 1 hour. That is false, all right? Each small square represents 30 minutes. It is the big square which represents 1 hour. Alert and action lines are separated by a difference of 4 hours. That is true. This statement is true. And recording is started at dilatation of 4 centimeters. This is also true statement. And first plot is done to the left of alert line. This is also true statement. All right. So this is how the questions about partogram can be asked. All right. So this is about partogram here. Next question, let us move on to question number 83 about labor. I told you I'll discuss question number 83. Now, here, internal rotation of the fetal head occurs when the head touches the pelvic floor. Okay, and once there was also this question asked that internal rotation happens earlier in primi or later in primi or whatever. So it is only 2 things which happen earlier in primi, that is engagement and effacement. Okay, engagement and effacement happens earlier in primi as compared to multigravidas, but your internal rotation in multigravidas and primigravidas, they happen at the same time. That is when the head touches the pelvic floor, that is at 0 station. Okay, and the factors that will promote internal rotation are good pelvis, okay, the normal gynecoid pelvis, good contractions, normal gynecoid pelvis, right, the good contractions, and the well flexed head. These are the things that favor internal rotation. Okay, so these are the favors. Now next is question number 77. Here, identify the type of pelvis. So in this pelvis, as you can see, this sacrum ala is absent. So this is the Naegeli's pelvis. This is the Naegeli's pelvis. All right, because the single ala is absent. If both would have been absent, it would have been a Robert's pelvis. This is a grossly deformed pelvis. Okay, so this is about Naegeli's pelvis, question number 77. Now let us move on to question number 124, or maybe we can come to 124 later after that. Let us see question number 106. Okay, question number 106, the question is asking, the partograph below portrays a labor curve for a woman, third gravida, para 2, 39 weeks. Membranes were ruptured at 4 centimeters. So you can see 4 centimeters membranes were ruptured, fluid was clear. There has been no indication of fetal distress, means everything, the fetal heart is going fine. Previous baby weights are this much. Estimated weight is this much. So what are they wanting to ask? They are asking what is the type of this graph. The graph is compatible with which of the following conditions? As I told you, as you can see here, that once it was 3 centimeters dilatation. This proceeded to a particular level, then it arrested for a while, and then it proceeded again, went back to normal. So this is the secondary arrest of dilatation. So this is secondary arrest of dilatation here in question number 106. All right, now let us move on to the next set of questions. The next set of questions that I'm going to discuss with you here begin with the next question which we left behind last time. And what is that next question? That next question is question number 11. Now we left it here. Let's look at this question number 11. The earliest sign of fetal life is best detected by. The answer to this is question number 11. The answer is option B, by real-time ultrasound. So the diagnosis of pregnancy in the early gestations is made by ultrasound. All right. And then similarly, question number 15 here, which says the best parameter measured by ultrasound to assess fetal maturity in the first trimester. So for fetal maturity means that is estimation of gestational age, right? So for estimation of gestational age, we use ultrasound parameters. The earlier done, the better. So the first trimester ultrasound is going to be the best for detection of first trimester, is better than second trimester ultrasound, right? So in this case, answer is crown rump length, which we see in the first trimester, not the BPD in the second trimester, right? So in this question, the answer is crown rump length because it is done in the first trimester, right? And first trimester, BPD is not done in the first trimester, BPD is done in the second trimester, right? This ratio of transverse diameter of abdomen to fetal head, this is not used, and the transverse diameter of abdomen, this AC, that is the abdominal circumference, it is measured for fetal growth rather than gestational age estimation. This is used for fetal growth. Now I want to talk about this topic in a little bit of more time. Let me talk about the diagnosis of pregnancy, the ultrasound diagnosis of pregnancy, all right, and estimation of gestational age. So I'm going to talk about the ultrasound diagnosis of pregnancy, right, and estimation of gestational age. This is a very important topic. Right. So for the diagnosis of pregnancy, let us talk about the diagnosis of pregnancy part first. So for the diagnosis of pregnancy, the first important point that I want to tell you is that the earliest sign of pregnancy anywhere, be it ectopic pregnancy or intrauterine pregnancy, earliest sign of pregnancy becomes a gestational sac. Okay, a sac-like structure inside the uterine cavity. A gestational sac, whether it is a true or false gestational sac, is different the matter, all right. So if it is a true gestational sac, or if it is a pseudo sac, a pseudo gestational sac is seen in the ectopic pregnancies, right? Seen in ectopic pregnancies. So in a pseudo sac, in a true gestational sac, what happens that this is the uterus, right, and this is the uterine stripe, this is the gestational sac. So a true gestational sac is eccentric, right, and it has these thickenings. Okay, it has the double decidual sac sign. These are the signs of true gestational sac. Okay, so true gestational sac would be eccentric and it will have this double decidual ring sign. Okay, it will have the double decidual ring sign, double decidual sac sign. So that is about the true gestational sac, whereas your pseudo sac will be something like this. It will be, this is the uterus and this is the cervix and this is the sac, this is the midline endometrius, sac is somewhere here. So this pseudo gestational sac here, it's central in location, it will have crenated margins and it will not have the double decidual sac sign, okay, DDSS. So it will not have the double decidual sac sign, that is going to be a pseudo sac, alright. So important point to remember is that a true gestational sac has a double decidual sac sign. So if you ask me, they ask you what is the earliest sign of pregnancy, it is gestational sac, right. But if they specifically mention that the earliest sign of intrauterine pregnancy, then the answer is a double decidual sac sign, okay, a double decidual sac sign. But if they ask you what is the earliest or most definitive, not earliest, sorry, what is the most definitive sign of a viable, most definitive sign of intrauterine pregnancy, okay, most definitive sign of intrauterine pregnancy, most definitive sign of intrauterine pregnancy, then the answer is double bleb sign. Then the answer is a double bleb sign. What is a double bleb sign? A double bleb sign is a yolk sac inside a gestational sac. That is the most definitive sign of an intrauterine pregnancy. Okay, that is the most definitive sign of an intrauterine pregnancy is a double bleb sign. The earliest sign of intrauterine pregnancy is a double decidual sac sign. The earliest sign of pregnancy is a gestational sac. This is the earliest sign of pregnancy, but the location of pregnancy can be different because depending upon whether it is a true gestational sac or whether it is a pseudo gestational sac, right? Now, what kind of questions do they ask in this? They sometimes ask you, that when can the gestational sac be seen at the earliest, okay. They ask you the timing of visualizing on these structures. So gestational sac or timing of visualization, okay, on TVS and on transabdominal this thing, okay. So on TVS, on TS, so for a gestational sac, the timing of visualization on TVS is as early as 4.1 to 4.3 weeks, okay. So this is earliest, okay, on an average by about 4.5 weeks. Alright, so gestational sac can be seen earliest on TVS at 4.1 to 4.2 weeks, on an average by 4.5 weeks. By transabdominal, they can be seen by about 5 weeks, okay, a week later. Yolk sac can be seen earliest by 5 weeks. And your cardiac activity can be seen earliest on transvaginal sonography by 5 to 6 weeks. If they ask you to choose 1, 5. Transabdominal 6 to 7 weeks. If they ask you to choose 1, 6 is the answer. Alright. Now if in the question they are not specifying, they are asking gestational sac can be seen or cardiac activity can be seen earliest by ultrasound. If they are not specifying whether TVS or TAS, then we go for TAS. We mark what is the answer for TAS, transabdominal, because whatever is seen on transabdominal is seen on transvaginal. So if they ask you earliest G-sac seen on ultrasound and they are not specifying whether it is transvaginal or transabdominal, then we go for the answer that is the transabdominal one. Okay. So this is about the timing of visualization of each of these structures. All right. Now let us talk about the dating. Okay, let us see this. Now, I wanted to talk to you about this ultrasound diagnosis of pregnancy, and here I have these slides to show you so that we remember and you know that what you have to see in these slides. This slide here, this slide here, this is a true gestational sac. This is a true gestational sac because this has the double decidual sac sign. Okay, this is the double decidual sac sign, this is the gestational sac, and two concentric white rings around it. There is a decidua capsularis and there is a decidua paritalis. Okay, these two concentric white lines, they make up the decidual sac. So this is, here is a true gestational sac. This is a gestational sac. Inside there is a gestational sac. Inside there is another thin white sac which is the yolk sac. So this is the double bleb sign, or in other words that this is the yolk sac inside the gestational sac. Right? If you see this outside, this is a big sac, then there is a gestational sac, inside there is the embryo. Okay, so inside there is the embryo, this white structure here is the embryo. So this is the embryo that you can see, this is the embryo. And once this embryo is around 5 mm, usually a cardiac activity can be seen. Okay, once the length of this embryo, once the length of this embryo is around 5 mm, the cardiac activity can be seen usually, right? If you see, however, on the other hand, this is a sac which has crenated margins. This is a true sac, but you see here that the mean sac diameter in this diagram has been given as 27 mm. This is a sac, this is a gestational sac which mean sac diameter 27 mm. It is a very big sac, but there is no fetal pole. So this is what is the current diagnosis of early fetal loss. Okay, this is the current diagnosis of early fetal loss, or early pregnancy loss. Okay, where it is said that if the mean sac diameter is more than equal to 25 mm, or if the crown rump length is more than equal to 7 mm and there is no fetal pole in the first situation. Okay, so if mean sac diameter more than 25 mm and no fetal pole, if CRL more than equal to 7 mm and no cardiac activity, that means the diagnosis of it is early pregnancy loss. So these are the two diagnostic features of early pregnancy loss which we should remember. All right, coming to the next slide here. Yeah, so this is about the ultrasound. This is about the ultrasound estimation of gestational age. Okay, this is about the ultrasound estimation of gestational age that I want to talk about. So if you see here in the first figure, this is what we are measuring, the crown rump length. This is what we are measuring, the CRL, crown rump length. Okay, now the crown rump length is the best. It is measured between it is best if measured between 7 to 10 weeks, right? However, it can be measured up till 14 weeks. Okay, so it's not like we cannot measure CRL beyond 10 weeks. We can measure it up till 14 weeks, but it is best when it is measured between 7 to 10 weeks, right? Next important point is that the CRL in mm plus 6.5 is equal to the gestational age in weeks, right? CRL is the best parameter for estimation of gestational age, especially if done between 7 to 10 weeks, okay? Then next here in this diagram, this is the biparietal diameter. This is another important point about CRL is the fetus should be in a neutral position. Fetus is in a neutral position. Fetus should be in a sagittal plane. Okay, so this is how it is measured. Coming on to the next parameter of ultrasound estimation of gestation, this is the measurement of biparietal diameter. This biparietal diameter is measured in the second trimester, right? And for the second trimester, the best parameter is the biparietal diameter. Here, this from outer table of one side to the inner table of the other side. Outer table to the inner table, it is measured in the thalamic plane, transthalamic plane. We can see the thalami, peduncles on the both sides. So it is seen in the transthalamic plane. That is important point, right? So this is about the CRL, right? And it is important that this is about the BPD. It is important that the BPD is important whenever it is a round head. Okay, sometimes there can be an abnormally shaped head like dolichocephaly or brachycephaly. Then in those situations, if the head is dolichocephalic or brachycephalic, then in that cases your head circumference is better than the biparietal diameter. Okay. Similarly, here in this figure here, this we are measuring the femur length. This here is measuring the femur length. This is the femur length. This is the femur length. FL for the third trimester. For the third trimester, we use FL. Ideally, in the third trimester, ideally, we use the combined parameters. Okay, we don't rely on one parameter per se in the third trimester. We rely on a combination of parameters, but if you have to choose one for the third trimester, we go for FL. This is FL. FL being the most reproducible of all the parameters. FL being the most reproducible of all the parameters. And in this figure here, what we are measuring is the abdominal circumference. What we are measuring is the abdominal circumference. What we are seeing, this is the abdominal circumference measuring on the outer border. Okay. What is important to remember here is that one hypoechoic round structure here, and this is the J-shaped hypoechoic structure here. So this J-shaped hypoechoic structure is the umbilical vein and the portal vein confluence and the stomach. They are seen on this plane, and that is the abdominal circumference. Okay, I think I have written something which you might not be able to see, so let me just okay, so let me just rewrite it here, that in the measurement of the abdominal circumference, this is measured all around the abdomen. In this, what we are seeing, this J-shaped area here and this round structure here, this J-shaped area, which is the area of confluence between the portal vein and the umbilical vein in the fetus and the stomach. Okay, these two structures are seen in this plane in which the abdominal circumference is measured. All right, and the another important point about abdominal circumference is that AC is the best single predictor. Okay, best single predictor for fetal growth. Okay, so if we take single predictor for fetal growth, means if we take all single predictor like AC versus BPD versus femur length, okay, then if we take those parameters, singly AC is the best. However, estimation of fetal weight estimation of fetal weight is done by a combination of parameters. Okay, it is done by a combination of parameters. Let me just write it on a paper. So USG estimation of fetal weight. That is done by a combination of parameters including the head circumference, BPD, femur length and abdominal circumference. These are all combined together by an ultrasound software, and it uses the formula which is most commonly, we have the Hadlock's formula, we have other formulas like the Shepherd's formula. So all these formulas, they can be used to incorporate all the measurements in millimeters given by these parameters, and they are all combined to give us an estimated fetal weight. So this is about the estimation of fetal weight. All right. So estimation of fetal weight gives us an idea of the fetal growth. So combined parameter is always better, but if you asked as a single parameter, AC is best for fetal growth. Diagnosis. Okay, so this is the important point that you should remember. Another important point about femur length, about all these important points, let me tell you about important points about femur length. Femur length is also a soft marker for Down syndrome. Okay, in that case the femur length is shortened. Okay, short femur. So short femur is also a shortened femur is also a soft marker for Down syndrome. That is one point. Extremely short femur, right? That means that it is below the 5th centile. Then it can mean that there is skeletal dysplasia. Then we should rule out skeletal dysplasia. So these are the important points about ultrasound estimation of gestational age. So for ultrasound estimation of gestational age, the best parameter is CRL, especially if done in first trimester, right? For example, if I have to choose between CRL at 14 weeks and BPD at 14 weeks, which is better? If these are the two options, then which is better? Then BPD at 14 weeks is better. Okay, but CRL if done in first trimester, ideally between 7 to 10 weeks, then this is the best. Okay, so this is about the ultrasound diagnosis of pregnancy. All right, now let us moving on to the next question. Next question, question number 12. In postmenopausal women, predominant vaginal cells are the correct answer is option A. In postmenopausal women, the predominant vaginal cells are parabasal cells, because the parabasal cells are the cells which proliferate or which predominate in the absence of any hormonal stimulation. So what we are seeing by this is something which we call as vaginal cytology. We are seeing for the vaginal cytological changes, and what we are seeing in vaginal cytology, what we are important point to remember is that the sample that we are taking is being taken from the lateral fornix. Unlike when we take a sample for pap smear, these are questions that are asked. When we take a sample for pap smear, the sample is taken from the ectocervix, and when we take a sample for vaginal cytology, we take a sample for the lateral fornix. Okay, so this is important. Now what we are saying that The type of cells which are there can tell us whether what kind of a hormonal stimulus it is. So what we are seeing in vaginal cytology, we are seeing the maturation index, okay, this MI. Maturation index is a ratio of the parabasal cells, right, is to the intermediate cells, all right, and is to the superficial cells, right. These superficial cells in the vagina, okay, these parabasal cells, they are, you know, dark blue. These superficial cells in the vagina, they have a high karyopyknotic index, okay. So this is the superficial cells. We have the parabasal or intermediate cells, and we have the superficial cells, okay. These are the mature cells. Superficial cells are the mature cells with pycnitic nuclei. Okay, superficial cells, they are seen in the presence of estrogen. Intermediate cells, they are, so superficial cells are seen in the presence of estrogen. Intermediate cells are seen in the presence of progesterone, and basal cells, parabasal cells and basal cells are seen in the absence of hormonal stimulus. No hormonal stimulus means parabasal cells are there, right. So this ratio of parabasal or maturation index varies with the age of the woman or the reproductive lifespan of the woman. Like for example, during the time of ovulation, there is more of estrogen, so this ratio is 0 is to 30 is to 70. In other words, you know, there is right shift, it can be said, in the maturation index, okay. So there is a right shift, okay. Then in pregnancy, there is more of progesterone, so the ratio is 0, 95 and 5. This is because of the progesterone. Postpartum, suddenly all the hormones come crashing down. There is no hormonal stimulus, that is 100 is to 0 is to 0. Menopause, in early menopause, the ratio is 50 is to 50, okay, equal. But late menopause, when there is atrophic in late menopause, then the ratio is 100, predominated by the parabasal cells, right. Then there is another index which is called as the karyopyknotic index. Karyopyknotic index. Karyopyknotic index or KPI is also called as the cornification index. Now this cornification index, you have to remember, it is the ratio of the superficial cells divided by the intermediate plus basal cells. So obviously it is going to be maximum with estrogen, so it is maximum on the day of ovulation. So this was the question that was asked, that when is the karyopyknotic index maximum? So it was maximum on the day of ovulation, alright. Similarly, you should also remember the maturation index on the day of ovulation, it shifts to right. There are more of superficial cells as compared to the intermediate cells, alright. Similarly, postpartum, again it is parabasal cells predominate. Late menopause, atrophic, again it is the parabasal cells which predominate. So these are the important points that you have to remember. All right. Okay. Now coming on to the next question. Question number 13, what is the name of the maneuver given below? Yes, the name of this maneuver here is the Ritzin maneuver. This is the Ritzin maneuver. As you can see, Lofsitz, Pinards and Bern Marshall, I have told you these are maneuvers in breech. They have already discussed with you in the first part of this discussion about the obstetric maneuvers. So this is Ritzin maneuver. This is for delivery of the head. This is basically for controlled delivery of head. Controlled delivery of head, you know, in between contractions. Right, controlled delivery of head in between contractions. This Ritzin maneuver is for controlled delivery of head in between contractions. Okay. They basically help in preventing perineal trauma during delivery. Another important point that you have to remember about prevention of perineal trauma in delivery is that what does not prevent against perineal trauma. So against perineal injury or another matter, that the answer to that question is episiotomy. Okay, so episiotomy is not a routine. Episiotomy is not a routine, and it does not prevent against perineal injuries as a routine. Okay, so that is what it is, important point here. Now next question number 14, fimbriectomy is also known as Kroner's procedure. This is the latest question here, latest asked in the latest NEET examination. Fimbriectomy is also known as Kroner's procedure. If you talk about what is the most commonly employed procedure, we have the Irving's procedure and we have the Pomeroy's procedure. Here we have the Kroner's procedure. The fimbriectomy is known as Kroner's procedure. It is simply removal of the fimbria. We have the Pomeroy's method for tubal ligation, and we have the, so if you talk about Kroner's method is fimbriectomy. Okay, if you talk about Pomeroy's method, this is the most commonly done method. Then we have the Parkland method, which is also known as the modified Pomeroy's. Okay, Parkland is also known as modified Pomeroy's method. Pomeroy's, the failure rate is 0.02%. With Parkland, the failure rate is 0.0. Just a second. With Pomeroy's, the failure rate is 0.02%, and with Pomeroy's, the failure rate is 0.04%. Okay. Now, what is in Pomeroy's? In Pomeroy's, we are simply taking the tube and we are ligating here. Okay, this is the Pomeroy's method. We are making a loop of the tube, and then we are ligating it and tying a ligate around it, and then cutting this tube, then cutting this. Okay, so we get a cut segments like this, we get a ligated segment like this. This is the rest of the tube. So this is what we get. We've tied a ligature, and these are the two cut end of the tube. This cut end is removed. Okay, this is about the Pomeroy's. We simply ligate like this. Okay, then in Pomeroy's, what we do in modified Pomeroy's, what we do, we ligate the tubes, and the middle point is this segment, the middle segment in between the two ligatures. This segment is cut and removed. This is the Parkland's procedure or modified Pomeroy's procedure. Okay. The failure rate, okay, I have incorrectly written it. The failure rate is like this. So if you talk about which has the least failure rate among the two, the least failure rate is seen with modified Pomeroy's, also known as Parkland. So in the current method which are being practiced of tubal ligation, the least failure rate is seen with modified Pomeroy's, also known as Parkland. Okay, with the current methods. Otherwise, previously, when your cauteries were used, the least failure rate was seen with bipolar cautery, but that is no longer available. So we see the least failure rate is available is with the modified Pomeroy's method. Now coming on to the next question. 15th we have already done. Let us talk about question number 16. Question number 16 says maternal fetal question number 16, maternal serum alpha fetoprotein is raised in all of the following conditions except. So it is raised in all of the following conditions except answer is D, that is Down's syndrome. Rest in all other conditions the maternal alpha serum alpha fetoprotein is raised. Okay, so coming to this question now here, what about, let me just tell you some important points about alpha fetoprotein. So mostly the questions are asked in this scenario only, that wherever they are raised, where they are low. Okay, so what you have to remember is that first of all, as far as maternal serum alpha protein is concerned, the important points to remember is that it is synthesized by the fetus. Okay, it is synthesized by the fetus liver, the fetus yolk sac, fetus GIT, all these places, all right. So anywhere where the gut or any developmental problem with the fetus will lead to increased levels of AFP. All right, the maximum levels of maternal serum alpha fetoprotein, they are seen in the amniotic fluid. They are seen in the fetal serum, then they are seen in the amniotic fluid, and then they are seen in the maternal serum. Okay. Now, in the maternal serum, they are measured as nanogram per ml, but they are reported as multiples of medians. Okay, they are reported as multiples of medians. Anyways, what if the maternal serum alpha fetoprotein more than 2.5 multiples of median is something which is considered abnormally raised. Okay, if this is the situation, then what we have to do, raise maternal serum alpha protein levels. We should always do what? The next step in such a situation is a targeted sonography, because the most common cause among anomalies is a neural tube defects. Okay, so we have here conditions which causes raised maternal serum alpha protein levels and condition which causes decreased maternal serum alpha protein levels. So how will we remember? We will remember raised alpha fetoprotein levels. They are caused first of all by underestimated gestational age, because the levels they rise continuously with gestation. So underestimated gestational age is the first point to remember. Secondly, if there is fetal demise, once there is fetal demise, there is sudden release of the maternal sudden release of alpha fetoprotein into the maternal circulation. So initially the maternal serum alpha fetoprotein levels are raised. Okay, then twins, obviously more fetuses, more alpha fetoprotein. All right, so these are the three usual causes which are the commoner causes, right? Underestimated gestational age, fetal demise, and twin pregnancies. And the other is your very important open neural tube defects are more common, more than gastroschisis, and then we have the omphaloceal. Okay, these are the common defects. Apart from that, your esophageal intestinal obstructions, the sacrococcygeal teratoma, these are a multitude of other causes which can lead to, but these are the common ones. These are the common ones on which questions are usually asked. Underestimated gestational age, fetal demise, twins, open neural tube defects, gastroschisis, and omphaloceal. When we talk about decreased maternal serum alpha protein, we have to remember that there is again fetal demise. Once there is fetal demise, initially there is an increased alpha serum protein level, alpha fetoprotein level. Later on, because now fetus is no longer there to synthesize fresh alpha fetoprotein, ultimately the levels in the maternal serum are going to be falling down. Then we have your overestimated gestational age. then trisomy 2118, gestational trophoblastic diseases, and abortions, or unhealthy pregnancy, right? Unhealthy pregnancy, the fetus is no longer, fetus is not healthy anymore. So only a healthy fetus with a healthy liver can synthesize your alpha fetoprotein level. So if the fetus is unhealthy, there is going to be less of alpha fetoprotein. So abortions is the answer there. You remember fetal demise, you remember overestimation gestational age, and you remember always remember in trisomy it is always decreased. Okay, always remember that in trisomy it is always decreased. So this is the important bit here. All right, now moving on to the next question. Question number 17. Question number 17, the following CTG indicates A, fetal head compression, B, cord compression, C, normal tracing, or D, fetal anemia. The correct answer to this is B, cord compression. Okay, the correct answer to this is B, cord compression. Why is it B, cord compression? Because these are variable decelerations. Okay, because these are variable decelerations, they have no relation with the contractions. One here coming with contraction, here there is no contraction, here also there is no contraction. So they bear no specific relation to contractions. That is why they are called as variable decelerations. Alright, now with this question, I want to talk to you people about and discuss about important points about CTG, cardiotocography. Let us talk about cardiotocography and what it entails. Now cardiotocography means the fetal heart rate is being measured, and the toco, that means simultaneously the uterine contractions are being measured, and this cardiotocography is performed when it is performed at the time of labor. Then it is called cardiotocography when we are, so this is intrapartum fetal monitoring. Intrapartum fetal monitoring that we are talking about. Okay, now let us talk about the various CTGs here. All right, so if we look at this here, if we look at it, what is this? What is this being done? This figure here, remember that this figure here, remember this figure here, this is our mother has something holding onto the hand. Okay, this is a knob that she is going to press every time she is going to perceive a fetal movement. This is for the fetal heart rate, one probe for the tocodynamometer for the fetal for the uterine contraction, measuring the intensity. So this is what is happening here. It is NST is being done, non-stress test. Okay, non-stress test. So non-stress test means that there is no other stressful factor there. First of all, important point is that there is no labor, nothing. The woman is lying comfortably. This is the whole machine. This is the paper trace that can be elicited. Now this is what the trace looks like. If you see in the first figure here, these lines here, these dots here, these are the fetal movements. These are the fetal movements that are being recorded when the woman presses this button. When the woman presses this button like this, these fetal movements are recorded. Simultaneously to these fetal movements, there is accelerations in the fetal heart rate. So you can see here that this is the baseline fetal heart rate, which is somewhere around 120 beats per minute. This baseline is not straight like this, but this is zigzag and wavy baseline. All right, so there is a baseline which is zigzag and wavy. So what we are seeing the baseline The baseline is around 100 to 160 per minute, that is normal. There is a beat to beat variability. This zigzag portion, this signifies the beat to beat variability, and normally this beat to beat variability should be 5 to 25 beats per minute. That means it is normal. Similarly, there has to be these acceleration. Acceleration means that the accelerations, they are present at least 2 in 20 minutes, each lasting for 15 seconds and 15 beats per minute. You understand my point? So for example, if it is a 120 baseline, at least 15 means that this acceleration should at least touch 135. Okay, it should not be a small acceleration. So baseline only this much. It should be good acceleration. So each acceleration at least 15-second duration and at least 15 beats per minute, and such acceleration should be present 2 in 20 minutes. If these criteria are there, then this is called a reactive NST. Reactive non-stress test means that the fetus is all okay. Okay. So this is a reactive NST. Similarly, if you see in the next graph here, this is a completely flat variability. There is variability almost gone. There is no variability. There is no zigzag wavy lines. No accelerations at all are seen. So this is a non-reactive NST. This is a non-reactive NST. Okay. So this is about NST. In NST, whenever we are seeing, so reactive NST means 2 accelerations in 20 minutes, each for 15 seconds, lasting more than 15 beats per minute. So this was about the reactive NST. When done at the time of labor, the lower part of the graph here, CTG trace here, shows the contractions. So these are the contractions, all right, and these are the decelerations. If you see, there is a difference between the first 2 decelerations and the third deceleration here. What is the difference? If you can appreciate, in the first 2 deceleration, what is happening, that the decelerations, and these are the contractions. So this is the deceleration, this is the fetal heart rate deceleration dip, and this is the uterine contractions. So if you can appreciate in this graph here, the dip, FHR dip, is coinciding with the fetal heart rate contraction. All right, so this is what is happening in this case. All right, so there is a slow decline from the baseline. There is a slow decline. Okay, this time period is around more than 30 seconds. Okay, this is slow decline. This is more than 30 seconds, and this is comprising. Now this happens, this is called as type 1 deceleration, also called as early deceleration, and this is because of head compression. This is important to remember, that if they ask you in the question that what kind of decelerations are these, you have to see them with the contraction. Now this is type 1, this is early deceleration with head compression. On the other hand, if you see here, what is happening here, that the deceleration, the dip of the deceleration is happening once the contraction is almost over. So what happens is that this is the contraction, right, and this is the fetal heart rate which is going. Now dip starts happening here and it is here. So this is called as late. There is a lag period of around more than 30 seconds here, right. So the contraction is over, yet the fetal heart rate has not recovered. On the other hand, in an early deceleration, when the contraction is over, the fetal heart rate has recovered back to its normal level. Alright, so this deceleration here is the type 2 deceleration, also called as late deceleration. This is seen because of uteroplacental insufficiency. Uteroplacental insufficiency or hypoxia, fetal hypoxia. Alright, so this is what is late deceleration looks like. This is the contraction here. With the peak of contraction, the fetal heart is okay, then it starts dipping. Once the contraction is over, it reaches the lower nadir of the deceleration. So there is a lag period. So this is type 1 and this is type 2 early late deceleration. Remember in which condition they are seen. The second type of trace, as we can see here, is this. What is this? This, on the other hand, is first of all, something that you can appreciate about the baseline is that though the baseline is around 150, 160 beats per minute, the baseline is quite high, but I want you to appreciate that in this figure, okay, okay, in this figure I want you to appreciate here what is happening, that this is our baseline, here is about 150 per minute, there is absolutely no variability, it is a flattish like trace, and these decelerations here, this deceleration, no relation with contractions, and you can see they sharply fall down, they are not falling down like this, so there is no lag period, they quickly form, sharply fall down, so there is this deceleration from the time of starting of deceleration to the dip, they are around less than 30 seconds duration, okay. This is very characteristic of variable deceleration. So variable deceleration, they reach from the baseline to the lowest point of their deceleration in less than 30 seconds, and they have no relation to, no definite relation to the pattern of contractions. So these are seen with cord compression, okay. Now there is another type of deceleration which is important to remember, and that is this deceleration. This deceleration here, this is a sine wave pattern, okay, sine wave pattern, a regular up down sine wave pattern of deceleration. This is called as the sinusoidal pattern. Now this sinusoidal pattern is very ominous, okay. The sinusoidal pattern means either there is severe hypoxia, severe fetal hypoxia and acidemia, okay, so very end change, okay, in the fetal well-being. So severe hypoxia, acidemia, and any condition where there is fetal anemia. So what can be the situations where there will be fetal anemia? Fetal anemia can be there in RH isoimmunization, okay, so RH isoimmunization, high drops, all this situation, TTTS, twin transfusion syndrome, where there will be one twin which will be anemic. So such sinusoidal heart pattern can be seen in RH immunization, high drops, in TTTS. Another situation where there can be fetal anemia is where the fetus bleeds. The fetus bleeds during labor or before labor or whenever, and such a situation can be there if there is vasa previa. So vasa previa is another situation where the fetus is going to have your bleeding. Vasa previa is another situation where there is going to be sinusoidal pattern, all right. So now we have something which is called as, whenever we are doing the cardiotrocography in labor, all right, we're always seeing what kind of a trace is it, okay. We are seeing whether in CTG in labor, and to answer clinical questions based on CTG in labor, we should remember that there is something called as type 1 category trace, there is a type 2 trace, and there is a type 3 trace, okay. So type 1 trace is something which is absolutely normal, very reassuring. Type 2 is something in between, and type 3 is something which is absolutely abnormal, and whenever there is a type 3 trace, delivery should be expedited. Expedited delivery, whether by cesarean section, whether by instrumentation, depending upon the PE findings, okay, and the other characteristics for instrumentation. So there has to be a type 3 trace, type 2 and type 1. So completely normal trace would be a baseline which is 110 to 160 per minute, right? A variability which is normal, 5 beats per minute, at least should be more than 5 beats per minute. Accelerations can be plus minus, if they are present that is a good sign, but isolated, remember, isolated absence of accelerations in the presence of variability and baseline being all normal is not an ominous sign. So isolated absence of accelerations is not ominous, okay. One thing, conclusion, we come to this. Secondly, there should be absence of decelerations. There should be no decelerations. Then this is type 1 trace, that means everything is going on fine. But then they have a type 3 trace. Type 3 trace is whenever there is absent variability, whenever there is absent variability with any of the following. What is any? With persistent late decelerations, with persistent variable decelerations, or bradycardia. Okay, so if there is persistent late decelerations with absent variability, persistent variable deceleration with absent variability, or bradycardia with absent variability, it is a type 3 trace. If it is a type 3 trace, means that immediate action needs to be taken. Immediate delivery has to be done. If criteria for instrumentation are met, then instrument should be applied. If criteria for instruments are not met and the delivery needs to be expedited, cesarean section should be done. Alright, so in whatever situation, if there is absent variability and either of these three, the baby needs to be immediately delivered. Second thing is if it is a sinusoidal pattern. Sinusoidal pattern means that the variability has completely gone now. It has become a sine wave kind of a pattern. So there is no baseline beat to beat variability that is anymore happening. It has become a sinusoidal pattern. So all these types of traces are type 3 trace. Whatever is in between is a type 2 trace. Whenever there is a type 2 trace in labor, we see what is the problem and we try to correct the problem. The problem could be at many levels. The problem could be that the contractions are too strong and that is causing head compression at the head jamming inside. So whenever there is type 2, we should do a PV. We should do a PV. Maybe there is an imminent delivery to rule out an imminent delivery. Alright, or to rule out a cord prolapse. We should stop oxytocin. Maybe it is excessive contractions. We should put the woman propped up, left lateral. Hydration should be improved, maternal hydration, and oxygen by mask. Okay, these situations, propped up, hydration, oxygen by mask, they improve fetal oxygenation. So all these things should be tried first and see if the fetal heart rate is improving. If it is not improving, then further action is required. Otherwise, this should be the initial management as far as type 2 decelerations, type 2 traces are concerned. So type 2 traces is a big list, okay. So we remember how to answer questions and how to go about it. We remember what is type 1, which is absolutely normal, and we remember what is type 3, which is absolutely abnormal, alright. And whatever is in between, it is type 2. And if it is type 2, we do not jump onto doing a cesarean section or an instrumentation immediately. We first try these methods. First we try these methods to see if the fetal heart rate improves or the CTG tracing improves. Alright, so we first try this, where we do a PV to rule out any imminent delivery, to rule out cord prolapse, we stop oxytocin, we put the woman in left lateral, improve hydration, give oxygen by mask, all in an effort to improve fetal oxygenation and see if the CTG trace improves and goes from being type 2 to being type 3. Okay, if that type 2 to type 1, if that happens, well and good, we continue the labor monitoring as it is. If that doesn't happen, then we have to intervene. So these are the important points that you should remember about the CTG in a nutshell. Alright, so very, very, very important. Alright, now let us move on to the next question, which is question number 18. Okay, question number 18 is asking regarding progesterone only pill, incorrect is. progesterone only pill. What is the incorrect statement? Ovulation is stopped completely. Ovulation can occur sometime, make cervical mucus thick and interfere with implantation. So the correct answer is option number 18A. So ovulation is stopped completely, that is the incorrect statement. But you have to remember that with POP also, if they ask you with POP what is the main mechanism of action, the answer is inhibition of ovulation. Okay, POP also makes the cervical mucus thick, POP also interferes with implantation, but the main mechanism of action is inhibition of ovulation, because the current progesterone only pill which is currently available in the market is the desogestrel containing pill. This desogestrel containing pill, it contains 75 milligrams of desogestrel. This is called as Cerazette. Okay, Cerazette is the currently available only marketed preparation of progesterone only pill, and its main mechanism of action is inhibition, and this inhibition of ovulation happens 70% of the times. Alright, so ovulation can occur sometime is the correct statement. Ovulation is stopped completely, it is the incorrect statement. Another important point about desogestrel is that the safe period with these desogestrel containing pills is 12 hours. Okay, that means that if you miss a pill for less than 12 hours, it is okay. Alright, so the importance being that earlier when the POP pills were introduced, the safe period was only 3 hours, but now with these desogestrel containing POPs, the safe period is 12 hours. Okay. Next question number 19. Oops. Yep. Question number 19. Which of the following includes the classical triad of enlarged upper part of uterus, soft lower part and firm cervix? So this is called as Hagar's sign. Very, very important when we talk about diagnosis of pregnancy. This is very, very important, Hagar's sign. Okay, so these are all the presumptive signs of pregnancy. The correct answer of question number 19 is A, Hagar's sign. Let us talk about what are the other signs which are mentioned in these. So these are the probable signs of pregnancy. Very, very important. All the signs that I am going to describe, they come by 8 weeks. Except for your Goodell sign, and your Hagar's sign. These come at 6 weeks, okay? These come at 6 weeks. Now, what is the sign? We have the Chadwick sign. Chadwick sign is also called as Jack Mears sign. Okay, Chadwick sign is also called as Jack Mears sign. I used to remember it as a wicked vagina, wick. So wicked vagina. So it is bluish discoloration of vagina. Okay, a wicked vagina. So this is the Chadwick sign. Second is your Osiander sign. Osiander sign, ocean has pulses. Ocean pulse, so pulsation, ocean pulse, pulsation in the lateral vaginal fornix, that is called as the Osiander sign. Then Goodell sign. Goodell sign means softening of the cervix. Very, very important. Goodell sign is softening of cervix. Hagar's sign is softening of the isthmus. And Goodell sign is softening of the cervix, right? Then fourth is your Palmer's sign. Palmer's sign is when you grasp the uterus in between the palms. The uterus has regular rhythmic contractions of the uterus, that is called as Palmer sign. Then we have the next sign which they say is the, another sign I want you to remember is Hartmann sign. Now Hartmann sign, okay, this is not a fifth sign here, let me just write it separately because it is not a sign of pregnancy as such. We have another sign which is called as Hartmann sign, and Hartmann sign is what? It is spotting during implantation. Spotting during implantation, that is Hartmann sign. Then we have another sign which is called as Pisca-Seck sign. This Pisca-Seck sign is basically lateral implantation. Lateral implantation, it is due to lateral implantation there is irregular enlargement. Irregular enlargement of uterus, that is Pisca-Seck sign, irregular enlargement of uterus. Then there is something which is also called as the Mittel-Schmerz. That is called as mid-cycle pain or ovulation pain. This happens because ovulatory cycles are painless, right? Ovulatory cycles are painful, and ovulatory cycles are, this is because of PG prostaglandins, PGE2 mainly, which is released at the time of ovulation. Alright, so this is about the various signs here. Next question, question number question number 21. 20 we have already done. Question number 21. In cervical tear repair, where is the first surgical stitch placed? So this is common sense that if the tear is here, right, then we place the first stitch anywhere tear, be it a cervical tear, be it an episiotomy, a vaginal tear, whichever tear, the first stitch is always above the angle. Okay, the first stitch is always above the angle. So cervical tear repair, let me just talk about what is the important thing here. Cervical tear needs to be repaired only and only if it is bleeding, okay? Because cervix is an area where if you take a number of sutures, then ultimately we're going to just keep applying sutures and sutures. So cervical tear needs to be repaired if it is actively bleeding. Other types of perineal injuries, we are going to talk about perineal tears and perineal tears during delivery. And these are very important because what is important is they can ask you about the grades of the perineal tear. We are going to talk about the episiotomy, what is an episiotomy and important bits thereof. So when we talk about the grades of the perineal tear, we have the grade 1 perineal tear, grade 2, 3A, 3B, 3C and 4th degree perineal tear. Okay, so these are the grades or degrees of perineal tear. So the first degree perineal tear is involving the skin or mucosa only. The second degree perineal tear involves the muscle layer also. Third is it has gone beyond the muscle and now it involves the what muscle? External anal, about the anal sphincter. So 3A is that it has involved less than 50% of external anal sphincter. 3B is it has involved more than 50% of external anal sphincter. 3C that the internal anal sphincter is involved. And 4th degree perineal tear is the complete perineal tear. CPT. Complete perineal tear or the rectal mucosa has also been involved. Alright. Now this episiotomy is a type of grade 2 perineal tear. Okay, episiotomy is a type of grade 2 perineal tear. Now if this is the vagina, opening, okay, this is the anus, this part here is the perineum. We can give a midline episiotomy or we can give a mediolateral episiotomy, alright. So if we give a midline episiotomy, the midline episiotomy disadvantage is that if it is going to extend, it is going to involve the external anal sphincter. Alright, this was a very big disadvantage, okay. And the other than that, the midline episiotomy, it heals better, it bleeds less, okay, it heals better, it bleeds less, it causes less dyspareunia, causes less pain. But if it extends, it will involve the external anal sphincter. This is one big disadvantage with the midline episiotomy. If you talk about the mediolateral episiotomy on the other hand, the mediolateral episiotomy, if it extends, okay, it is going to spare the external anal sphincter if it extends. This is the only advantage. Other than that, the mediolateral episiotomy bleeds more, it heals also less better, it causes more pain. It causes more pain, more bleeding. It heals longer, it takes longer time to heal, right. So we have to balance the advantage with the disadvantage. So the only advantage is this, that is why mediolateral episiotomy is usually preferred, okay. So what is preferred? We prefer mediolateral episiotomy, and importantly, it is not a routine because it has so many side effects. So it is not routine. So it is only given if required. Okay, so mediolateral episiotomy is the preferred episiotomy, but the caveat is that it is not done as a routine. It is only done as and when required. So if they ask you this question, what are the methods to prevent perineal tears? Okay, if they ask you this question, what are the methods to prevent perineal tears, then the answer is controlled delivery of head in between contractions. Okay, then perineal support, then maintain flexion of the head so that the smallest diameter emerges, right, maintain flexion of the head. And episiotomy, is an episiotomy method to prevent perineal tear? No. Routine episiotomy is not a method to prevent perineal tears, okay. So this is what is important, this is not a method to prevent perineal tears, okay. Secondly, important point, the third and the fourth degree of perineal tears, they are together called as OSS, okay. Obstetric anal sphincter injuries. Important point is that if they are identified immediately, like if it is a 4th degree perineal tear, it is identified immediately in labor room itself, okay, it should be treated it should be treated immediately there and then, alright. Okay, so better thing is that if it is identified immediately in the labor room, it should be treated stat, but it should be done in OT under complete vision, proper presentation, under anesthesia, proper anesthesia, not general anesthesia, adequate anesthesia, it could be epidural, it could be a saddle block, whatever. So it is done in OT under anesthesia and under supervision by senior, right. And the sequence of repair, remember that the sequence of repair is the rectal mucosa, then the internal anal sphincter, then external anal sphincter, then the muscle, and then the mucosa and skin, right, obviously, then the vaginal mucosa and skin. Important point to remember is, okay, so whenever the obstetric anal sphincter injuries are identified, if they are identified in the labor room, they are treated stat. If the obstetric anal sphincter injuries, they are identified late, that is more than 24 hours later, then the repair is delayed, then the repair after 6 weeks. After 6 to 12 weeks, okay, then the repair is definitely deferred to after 6 to 12 weeks. Now the sequence of repair is rectal mucosa, internal anal sphincter, external anal sphincter, then muscle. Muscles are the perineal muscles, which are the superficial and deep transverse perineal muscles, and the skin and mucosa is the last layer. Importantly, for the external anal sphincter, two techniques are there, end-to-end and overlapping. End-to-end anastomosis is the preferred technique. Okay, and the suture that is used is Vicryl, which is, trade name is Vicryl, it is polyglactin 910, right, that is Vicryl, the trade name is polyglactin 910. So this is about your question number 21. Let us talk about the next question.